Firstly, thank you very much to Dr. Schulman and the organising committee for having me and giving me an opportunity to present this interesting case study that came along this year when I was a registrar. So this is a 10-year-old girl that presented to the ophthalmologist with dramatic and rapidly progressive vision loss over several days. Initially, that began with a loss of ability to discriminate colour desaturation, and mild retrobulbar ache behind both eyes exacerbated by eye movements. No previous history suggestive of any systemic illness or infective neuroretinitis or myelitis, and no preceding any history of viral or bacterial illness. Examination-wise, she had a visual acuity of less than 6 out of 120, almost complete blindness, no macular scar, optic disc swelling and papillar edema. Normal thorough neurological examination, no cranial nerve findings, normal limb, tone, power, reflexes and sensory examination, normal coordination. On an urgent MRI that was done and obtained of T1 axial and gadolinium sequences, this showed bilateral enhancement of the optic nerves, as you can see here. And this is consistent with optic neuritis, obviously. And this is seen within the proximal aspect of the optic nerves bilaterally, and also just distal to the optic chiasm, and also within the retrobulbar segments. There's also subtle evidence for papillar edema with mild expansion of the CSS space. And if you can just put your eyes over there where the arrow is, I'm not sure you can see it, but there's a bit of an optic nerve head protrusion consistent with papillar edema as well. So this was the MRI scan that was done for this little girl. And this is another close-up of the same MRI sequence of T1 axial and gadolinium. No space-occupying lesion demonstrated, no other arterial malformation, and no other demyelinating lesions identified besides that in the optic nerves bilaterally. So otherwise normal intracranial appearances. So optic neuritis simply denotes inflammation of the optic nerve, and one of the more common causes for optic neuropathy. In acute settings, swelling is commonly seen within the retrobulbar intraorbital segment of the optic nerve and commonly characterized by period neuritis with enlarged, enhancing optic nerve, and may be associated with persistent T2 high signal change. And additionally, there may be contrast enhancement best seen on fat-suppressed T1 axial and coronal images, and seen best in acute patients presenting within 20 days. Chronic changes include a persistent T2 hypersignal change in an atrophied, non-enhancing optic nerve. This axial contrast-enhanced fat-suppressed T1 image demonstrates perineuritis where the arrow is, with thickening enhancement involving the right optic nerve. Although affected optic nerves were best appreciated on T1 and contrast sequences for our patients in our study, there were also subtle findings on T2 sequences with just T2 hyper-intense signal just in the proximal optic nerves bilaterally, and subtle T2 signals within optic nerves on the coronals as well. So how does optic neuritis differ from adults in paediatrics? Presentation is usually unilateral for adults as opposed to bilateral for children. Pain is exacerbated by eye movements in adults, whilst associated with generalized headaches in children. And more specifically, however, whilst the cause is usually idiopathic in adults, it is more associated with demyelination and subsequent diagnosis of MS. Whereas in children, the cause is often post-infectious or post-immunization, with lowered probability of recurrent demyelinating events or diagnosis of multiple sclerosis. In children, usually presents as an isolated event, usually in those who've had no previous history of any central demyelinating events. Optic neuritis is usually bilateral in over 50% of children younger than 12 to 15. And as noted, usually associated with generalized headaches, but may also have painful eye movements. Symptoms progress rapidly and usually over several hours to several days, and may be associated with partial or complete visual loss. As in our MRI case, optic nerve can also appear swollen in over 75% of children. Neuromyelitis optic antibodies returned negative for our patient. CSS was normal, but anti-MOG antibodies returned positive. So I did a quick survey around the department earlier this year. And usually the first thing that everyone thinks of with optic neuritis is MS. However, there are many other causes for optic neuritis, including ADEM, neuromyelitis optica, SLE, sarcoid toxins, and so the list goes on, but also other infective causes such as varicella and herpes. But one that not everyone may have heard of is anti-MOG antibodies. So the objective of this presentation is to bring to attention and to light some of the rarer causes of optic neuritis seen in a paediatric population that's relevant for us as radiologists. So MOG stands for myelin oligodendrocyte glycoprotein, a myelin protein that was discovered 30 years ago. It was initially received an enormous interest in pneumoimmunology and one of the main autoantigens used in experimental models for MS. Many papers were published during the time, as it was thought that MOG antibodies were thought to be a key autoantigen in MS, but results were somewhat contradictory. About 5 to 6 years ago, interest of MOG again resurfaced when there were more specific assays to detect these autoantibodies. And interestingly, the association now is with pediatric demyelinating disease, including ADEM, optic neuritis, and neuromyelitis spectrum disorders. It is a relatively new association. The epidemiology and incidence of this condition is yet to be verified and reported. Of the 1/3 of patients who've had anti-MOG antibody-associated optic neuritis, they can present with bilateral, longitudinal, extensive involvement of the optic nerves, which commonly involve the anterior visual pathway. And as seen in our case study, there is also associated optic nerve head swelling and commonly involving the retroorbit bulbar optic nerve. It appears that anti-MOG antibodies patients have a unique radiology and clinical profile and is a distinct clinical subset of optic neuritis. MOG antibody positive patients appear to have rapid response to steroids and plasma exchange and hence needs to be considered as an early differential. And whilst it may be a clinically isolated syndrome, there appears to be a tendency to relapse rapidly on steroid withdrawal or cessation, and it's been reported in literature that maintenance with immunosuppression is required in some patients, although this is less necessary in children than adults. Some recent literature reports correlation and association between anti-MOG antibodies, recurrent or chronic relapsing inflammatory optic neuritis. So how do you investigate for optic neuritis? This is a neuroimmunology paper that was published this year from Westmead in Sydney, but provides a detailed review of the history of anti-MOG antibodies and its role as a serum biomarker for demyelination. This group proposed an algorithm for investigation of a first episode optic neuritis. It looks extremely scary, but we can break that down and it will make a lot of sense. And it's based on clinical radiology and laboratory findings and features. And it's helpful for radiologists to consider some of the initial causes of optic neuritis and signal changes within the optic nerves based on the history provided. So let's break that down. When a child presents with first episode optic neuritis with systemic involvement, this would be classified as an atypical optic neuritis. Hence, you would be considering some of the infectious causes of optic neuritis, including sarcoid and vasculitis. But if the child presents with optic neuritis but no systemic involvement, you would proceed with an MRI and lumbar puncture, obviously. But if the MRI is not diagnostic for MS, and there are no intrathecal oligobands on CSF studies, and there is also extensive longitudinal optic neuritis seen on your MRI, which is exactly what our child had, then consideration for antibody-associated optic neuritis should be made. Once you've considered for antibody-associated optic neuritis, you check for MRI features for optic disc swelling and prominent retrobulbar optic nerve changes and rapid steroid sensitivity clinically. Our patient ticked all of these boxes. And following this algorithm, you would test for MOG antibodies on serum or CSF. And if positive, the first-line treatment is with steroids, plasmapheresis, and possibly immunosuppression as a second-line treatment. Now, this is important because children respond very quickly. However, if you consider antibody-associated optic neuritis, but there are no MRI features of optic disc swelling, prominent intracranial optic nerve changes, chiasmal involvement, or optic tract involvement, then consideration should be made for AQP4 antibodies, which test for neuromyelitis optica. So what exactly is neuromyelitis optica? It's an inflammatory disorder of the CNS with severe immune-related demyelination and axonal damage, predominantly targeting optic nerves and spinal cord. to recognize a distinct clinical entity based on the presence of disease-specific anti-aquaporin 4 antibody. The hallmarks in children include acute attacks of bilateral and rapidly sequential optic neuritis and transverse myelitis. Clinical neuromyelitis optica can progress with severe disability at the time of presentation, with severe attacks of myelitis or optic neuritis, and should raise suspicion for this entity. And some children have additional lesions on brain MRI resembling those on MS or ADEM. NMO can be associated with transverse myelitis with a contiguous spinal cord lesion or MRI, as you can see there, extending 3 or more segments. In this case, there's also abnormal signal within the inferior aspect of the body of the corpus callosum. So going back to the first episode of optic neuritis algorithm, what if there was unilateral optic neuritis without systemic involvement? You would check for MRI if there was any suspicion for MS, any intrathecal oligobands, and perhaps more focal optic nerve involvement, and monitoring as per MS. Paediatric MS is a rare entity, occurring in less than 5% of patients who have MS, and children are more likely to present with isolated optic neuritis, isolated brainstem syndrome, or encephalitic syndrome symptoms such as headaches, vomiting, seizures, or altered consciousness. Over 95% of children have relapsing MS characterized by intermittent attacks of increased disability followed by partial or complete recovery. So if you've seen anti-MOG, NMO, and MS all cause optic neuritis, so is there any possibility of telling the difference between these entities on MRI alone? Current literature tells us that optic nerve head swelling is much more commonly seen with anti-MOG optic neuritis. Bilateral optic nerve involvement is much more common with anti-MOG and NMO than it is with MS. Optic tract involvement is also much more common with NMO. Whilst retrobulbar involvement is seen mostly with anti-MOG, absence of other brain MRI abnormalities is a good discrimination between anti-MOG and MMO, with MS likely associated with other lesions. Additionally, neuromyelitis optica can be associated with transverse myelitis with contiguous spinal cord lesion, as we have seen. Now, one of the last entities we'll go through that we have not studied yet, but can also cause optic neuritis involvement is ADEM. This was a child that presented to our center with multiple new T2 flare signal, hypersignal lesions in the subcortical white matter where the arrow is, and multiple other lesions. The patient also had unilateral left-sided optic neuritis from thickening of the left optic nerve, which is not seen on this. So what exactly is ADEM? ADEM is characterized by acute or subacute onset of multifocal neurological deficits with encephalopathy, often following viral illness or vaccination in children. The clinical presentation is usually a polyfocal CNS event with presumed inflammatory demyelinating cause, associated with encephalopathy but not explained by fever, systemic illness, or post-ictal symptoms. And specifically for us, no new MRI findings after 3 months, but may be abnormal during the acute phase. MRI demonstrates widespread asymmetrical white and grey matter abnormalities, including diffuse, poorly defined, large lesions within the white matter and grey white matter lesions, particularly within the basal ganglia and thalamus. T1 hypointense lesions in the white matter are rarer. So can you differentiate between ADEM and MS? ADEM usually has more white matter lesions, are larger bilaterally and asymmetrical. Lesions are also more poorly defined and better defined with MS. Periventricular lesions are less common with ADEM than it is with MS, and thalamic lesions are more common in ADEM as well. And presence of brain lesions about the same age on MR is consistent with ADEM. So this is a case of MS, with hyperintense periventricular white matter scattered lesions seen on FLAIR. Obviously, this differs from ADEM, as it is more commonly periventricular in the latter case. So in our case study, this child was treated with high-dose prednisolone pulse therapy over 3 days with dramatic improvement. After the 3rd dose, visual acuity was almost back to normal, 6/12 in each eye, and noticeably improvement in optic disc swelling, and at 2 months almost completely back to normal with a normal neurological examination. So the take-home message from today is to consider other causes of optic neuritis in children, particularly when there is bilateral optic involvement. Antibody-associated optic neuritis respond very quickly to high-dose steroids and should be thought as a differential diagnosis from our point of view, so clinical treatment is not delayed. Thank you.